please give us some insight regarding the CMS oversight for 2022, how were inspections moving through COVID, and what should providers and healthcare organizations expect in the next coming 12 to 24 months?
Sure.
Please.
So basically, in March 4 of 2020, CMS, if you may remember or not, stopped any surveys except those that were IJs, immediate jeopardy situations. That includes EMTALAs, as well as any sort of infection control. So this is slowly ramping up. They did remove the restrictions, but I mean, there's obviously a backlog, and then it's going to take some time to address all of those. But going forward, there is guidance for resuming the recertification surveys as well. That includes anything to make sure that JCO did it right, etc., as well as the COVID-19 focused infection control surveys, as well as the new issues surrounding the vaccine mandate. So in my opinion, the more COVID subsides, the more there's going to be a push to make sure that these past couple of years, the providers that have not been visited and that may have gotten relaxed are going to be met with surveyors. And that also goes with saying that for some aspects of MIPS, all you have to do is attest that you're doing something. But you need to ensure that your documentation is in tip-top shape in case there's an audit down the line or in case someone comes knocking at your door and wanting to see your records. So I think most providers this year, especially most healthcare organizations, can look forward to increased presence of both state surveyors and both Joint Commission, DNV, or whomever they may be accredited by.
So I think that the deeming authorities are going to be very much involved going forward, and people that aren't meeting the conditions of participation of Medicare are potentially going to have a rough time of it. We have a lot of physicians and executives who are really dedicated to their patients. So I'm so pleased that you and Stan's organization are taking these steps to help them survive in a somewhat hostile environment. Stan, could you explain how you can help a physician's practice meet some of these Byzantine requirements?
Absolutely. So I want to leave everybody on a positive note, but I want to stress the point that it's extremely important not to treat numbers, but to actually treat patients. So it is extremely important in today's environment to look at your patient population, look at the data, utilize technologies to look at the data, because without technologies, there's no way you can have visibility and be able to identify risks and make sure that we actually act upon the risk. So one of the strategies that we do, when we partner with an organization, we look at their patient population. We break them down by systems, by the disease states, by diagnosis. We look at quality measures that exist within the practice, and we see whether that was effective. That includes full review of their Medicare star rating. If they're part of an IPA or a part of an ACO, we would look at the performance of the organizations and see the weak points and identify where the practice wants to take this and how serious they are regarding their compliance and regarding improving of their patient clinical outcomes. Now, as long as we have the participation of our organization, we would help them organize and select reasonable and actionable items that they can accomplish and set up key performance indicators, strategies, and document strategies, assign responsibilities across the organization, and look at the milestones and the resources that are going to be required to make sure that we can actually deliver. That means we would make sure that there are documented clinical protocols that are set for the practice per disease state. Currently, we're covering 17 disease states. That means every single disease state, we will try to make sure we document on the provider level or on the organization level all the potential medical care gaps that could arise through encounters with patients, as well as all the action plans that need to come into play when we identify those gaps to make sure that we close off the gaps and reduce the risk. Dr. Erdik, would you like to add on to what I just said?
Sure. I mean, if you look at it from a clinical perspective more, it is, as we've been saying, less of becoming a transactional, are you sure this patient is prescribed an insulin, to more of a, how can we assure that this patient is actually taking that insulin? And that brings a lot of challenges. So chronic care management is becoming more and more important. So you need to have nurses on standby to ensure that the patients have access, or you need to make sure that if the patient's blood pressure is suddenly 180 over 110, are they taking their pill before showing up to the ER? And with that, I think chronic care management is the way to the future, especially CMS, knowing that CMS also allows for outsourcing billing of chronic care management.
As you probably know, medication abandonment is a very serious problem. And much of that medication abandonment is due to sticker shock when they get to the pharmacy. In fact, sticker shock when they get to the pharmacy is a bigger cause of medication abandonment than even side effects. So there is software now that allows the doctor to tell the patient what out-of-pocket costs they're likely to face at the nearest 5 pharmacies. And if the patient says that he can't afford to take that medication, the doctor can discuss with them an alternative medication or an alternative treatment. Perhaps it doesn't include medication. Do you have any access to this type of software? Because it's great for the patient, prevents medication abandonment, and it's important for the physician too, because what typically happens is the patient gets to the pharmacy, they find out that they can't pay for it, they call the doctor's office. By that time, the doctor's already seeing the next patient and isn't available. And there are 3 and 4 phone calls back and forth, consuming a tremendous amount of staff time and expense and engendering tremendous frustration. So just giving access to that type of software, and the APIs exist now to make this part of the doctor's workflow embedded in the EMR. Do you have any knowledge or interest with that? Interest in that?
I could respond. Yes, we're definitely aware of the software technologies, but just keeping in mind that our focus is geriatric patient population, so majority of our patients do have insurance that would pay for the drugs, so the cost would not be a barrier. In fact, where we do see barriers is lack of compliance, lack of patient education within this disease states, lack of their understanding of the symptoms, what they might be experiencing, as well as lack of care coordination. When I give you an example, patient has seen an internal medicine doctor, their PCP, that doctor referred them out to an endocrinologist and has never received the referral documentation back. Therefore, hasn't consolidated their care planning, and endocrinologist, if the patient actually made it there, endocrinologist did something of his own or her own, and internal medicine or PCP is doing something else. And there is no consolidated care planning, so the patient is following 2 directions or often falling into the crack and not following the one or the other.
Absolutely. A high functioning organization. A
Yes,
high functioning organization would deal with that.
yes,
And if you can help them deal with that, you're
yes. So
providing
tracing of
great service.
referrals, looking at gaps, identifying patients that are not complying, and actually leading them to make sure that they do close off those gaps on the provider side, and educating the patients and their family on the importance of compliance on the patient side, because education goes a long way. We say that the patient that's invested in their care is going to statistically and clinically do much better than the patient is not educated at all. I'll say that currently the providers that we see are usually being reactive, not proactive. So they only know of a problem, or they're addressing a problem after the hospitalization has occurred, or after the patient already has a comorbidity or mortality, or unfortunately, or readmission to the hospital. So we want to make sure we stay on the proactive side. We want to make sure that we reduce the costs and we improve clinical outcomes as much as possible.
Very
That's our mission,
important.
that's our goal.
The patient should have an appointment to see the specialist before they leave the hospital. They shouldn't be told to leave the hospital and then call for an appointment. And the medical record should be in the doctor's office before the patient arrives. And in fact, AHRQ has shown that these things specifically lower the incidence of readmission. Very
100%.
important.
Right.
And in addition, having an educated staff member call the patient a day or two after discharge and make sure that they've purchased the medications is also very important. No question, anything you can do to help the doctors. The other thing, though, is I wouldn't underestimate medication abandonment for sticker shock, even in the geriatric population. It's very common. There's good data on that. It's something that I want to stress.
Yeah, 100% agreed.
Okay, anyway, I would just say for our audience, which is a lot of physicians, probably out of the 9,000, probably about, there's many thousands of physicians. For our audience, it's important to stress how the company can help them if we want to get.
We welcome inquiries, and we welcome the opportunity to explore potential partnerships with you. If we can feel that we can bring an add-on value to your organization, we definitely are willing to invest the time to explore those opportunities and see if we can absorb some of your performance risks and be a good strategic partner for you to clinically get to where you want to go from the patient care standpoint and from your compliance standpoint. Now, in parallel with that, Dr. Levien, I really want to thank you for having us here today. It's truly been an honor and a pleasure. Because of organizations like yours, we're able to spread the word, and we hope that this is going to make a difference. And we hope we're going to raise awareness for 2022 and for years to come. Thank you.
Well, thank you so much for participating. And I think your enterprise can go a long way to empower both patients and physicians. So thank you again.
Thank you, everybody.